Hello, my name's Patrick Foshchinsky, one of the third-year residents at Beaumont Royal Oak Emergency Medicine Program, here to give my talk on the impact of resuscitation resident on duration from ROSC to target temperature. So starting right off, the resuscitation rotation, it's a second-year rotation that allows a resident to function on and focus on the highest acuity emergency medicine patients available in our department. And these patients include out-of-hospital cardiac arrest patients typically. So the resus resident, or RR, functions as an extra physician beyond normal staffing levels and can offer active bedside management. And this is particularly useful in critically ill patients that require very hands-on management and often end up being patients such as those that have achieved return of spontaneous circulation, or ROSC. So following ROSC, priority is placed on the preservation of the neurologic function, and that's done in the form of initiation of targeted temperature management. So this is done by cooling a patient to 33.5 or 34 degrees Celsius at our institution, and a parallel investigation found by our research team has found a positive association between the presence of an RR and the provision of TTM. And since neurologic injury prevention after ROSC is time sensitive, our objective with the study was to assess the effect of an RR on the duration from ROSC to target temperature, or RTT. So going on to the materials and methods. So this study was done in our emergency department, a single site tertiary care level 1 trauma center, a census of over 130,000 visits annually. We performed a retrospective review of 152 patients that had out-of-hospital cardiac arrest with ROSC that underwent TTM to 33.5 degrees. This was done over the years of 2014 to 2019, and 2014 was the inception of the resuscitation rotation. We utilized a prospectively collected cardiac arrest database, and the patients were identified as cases with or without an RR, and multivariable linear regression analysis was employed to assess the effect of a resus resident on RTT. And we adjusted for characteristics such as sex, body mass index, arrest witness status, whether or not the arrest was witnessed by a bystander, and CPR bystander status, whether or not a bystander initiated CPR or if it was done by EMS, and the rhythm type and the initial core temperature. Our results showed that, so we had 152 adult out-of-hospital cardiac arrest patients attain ROSC and underwent TTM. 5 were excluded because those patients were transferred from a different facility where CPR and ROSC had occurred, and we wanted to make sure that we could fully assess the effect of the resus resident, and in those cases, no resus resident was involved, so that left 147 for our final analysis. Our multivariable linear regression analysis revealed that the resus resident is not associated with a decreased RTT when adjusting for patient characteristics. On the other hand, increased BMI, increased initial core temp, and shockable rhythm were associated with increases in RTT, and these make sense intuitively. If someone's BMI is higher, then it's going to take a longer amount of time for them to cool to the target temp. If someone's initial core temperature is elevated, and then it could also take a longer amount of time for them to cool to the targeted temperature. And with the shockable rhythm, these are cases that often go to the cath lab, and that can produce some delays in targeted temperature management. And sort of going on to the tables in the study. So table 1, it just shows the characteristics stratified by resus residents, showing that middle column shows 45 with resus resident involvement and 102 without real statistical significance, except in some of the categories in this chart. And then going on to the outcomes, dividing up the 2 categories, no major statistical significance between the 2. And then table 2 shows the multivariable modeling with ROSC to target temperature, and it shows in orange the resus resident. It shows there being no statistical significance association between the presence of an RR and the RTT, and then showing, as mentioned, the BMI, initial core temp, and shockable rhythm having a statistical significance, which results in an increased RTT. So in conclusions, the presence of an RR did not have a statistically significant impact on RTT, whereas increased BMI, core temperature, and shock algorithm were associated with prolonged RTT. And these are kind of variables that may confer hazard and require special attention in such cases. Here are my references, and thank you very much.